Hello and good evening all. We are going to continue our lecture on imaging. We've talked about x-rays, chest x-rays, abdominal x-rays, IVU, as well as RUG. So we are going to continue with barium studies. Now, when you talk about barium series, it's a contrast study that evaluates the gastrointestinal tract using barium salts. Barium salts or barium sulfate is the contrast. Usually it is a non-water soluble contrast. So because it is not soluble, it is not absorbed to give a systemic toxicity. However, when using barium contrast for study, if peradventure there is any leakage into the cavity, maybe of barium in a patient that has a perforated viscous, this leakage will lead to peritonitis if it is in the peritoneal cavity, or it could be mediastinitis if it is in the mediastinum. So now the various barium series include barium swallow, barium meal, follow through, then enema, barium enema. These are the various barium studies. Now for barium swallow, the barium contrast is aimed to outline the esophagus, okay? For barium meal is to outline the stomach. Follow through is to outline the small intestine. And of course, for enema is to outline the large intestine. Usually, there are various indications for barium studies. If you are doing barium swallow, the aim is to outline the esophagus and sometimes the upper part of the stomach. And the common indication for barium swallow is in patients with dysphagia from any cause. It might be dysphagia from stricture, dysphagia from a tumor, dysphagia from achalasia. Now, you request for barium swallow. However, it is contraindicated if you are suspecting a perforation, because as we mentioned, barium can incite an intense inflammation if there is a leakage into the cavity where that viscous is contained. So if you are suspecting an esophageal perforation, it is contraindicated. Okay. Barium swallow, you can see different views of this barium swallow. Now, this is a lateral view. and this is an anterior posterior view. You can see the contrast is outlining the pharynx and the esophagus. And you can see the lumen is filled with the contrast with no abnormality. There is no narrowing. There is no cessation of contrast. As well, there is no filling defect. If you look at the AP view, you can see it is showing a normal barium swallow. Now, if you look at this oblique view, this is an oblique view of barium. And you can see this oblique view is showing, including the upper parts of the stomach. Okay, in case you have narrowing, okay, of the lower esophageal sphincter. And also, you know, in achalasia, there's going to be dilatation here, as well as a bed-big appearance with absence of fundal gas. There will be absence of fundal gas. So this is barium swallow. You have AP lateral and an oblique view. Now, this is an image of a patient with dysphagia, okay? A patient with progressive dysphagia of maybe shorter duration, and a barium swallow was requested for. You can see this is an oblique view of barium. A mass in the mid-esophagus with shouldering effects, and irregular shadow. With an irregular shadow, you can see there is narrowing. If you compare the caliber of the proximal esophagus to the distal esophagus, you will notice there is narrowing of the distal esophagus. What are your differential diagnoses? Carcinoma, number 1. Why? You see the shouldering effect, filling defect, irregular shadow, as well as narrowing. Okay? It could be carcinoma of the esophagus. Now, you might be asked, what is your confirmatory test for the diagnosis? Is to do upper GI endoscopy and biopsy for histology. It is histology that will give you a definitive diagnosis. Also, you can do to rule out involvement of the bronchus. It can have, there can be invasion of the bronchus. Now, I had an experience when I was doing my cardiothoracic posting during my part 1 rotation. A patient came with bronchogenic carcinoma. So we were managing this patient, evaluating, requested for CT, okay, preparing this patient for treatment. Suddenly, this patient just disappeared. Subsequently, he now came back with dysphagia. So he caused a serious diagnostic dilemma. Why will this patient have dysphagia? What is actually going on? He now confused the entire team. And this patient refused to volunteer any history, not knowing that period he disappeared. He went and took a traditional concoction, and that now caused esophageal stricture. He now came back and confused us. It is after the barium swallow, we now saw an esophageal stricture, because initially we were managing him for bronchogenic carcinoma. And of course, we know if patient had esophageal tumor, he will have dysphagia before presenting with any bronchogenic symptoms if it has metastasized or if it has invaded the bronchus. But this guy, we know it was primarily a bronchogenic carcinoma. So and he kept quiet and left us in the dark. It was when one of his relatives came and told us that this guy, he went and took a traditional concoction. And it was then when he could no longer eat anything. That is when he now decided to return to the hospital. Of course, he knows he will have IV fluids and so on. Okay, so this image is showing a barium swallow, okay, of a patient who has esophageal carcinoma. You can see the shouldering effect here, irregular outline of the esophagus. And we said the barium swallow, you could have the AP, lateral, and the oblique view. Okay? So, now, this is also a barium swallow. You can see rat tail appearance of the distal end of the esophagus at the gastroesophageal junction. A huge dilated esophagus with narrow lower end. It is called the rat tail appearance, or sometimes the bed beak appearance. Okay, rat tail appearance or the bed beak appearance. Now, what is your differential diagnosis? Achalasia cardia. I told you the findings in achalasia cardia. You see a proximal dilated esophagus, narrowing with a bed beak or rat tail appearance. And at the oblique view, of course, when you look at the stomach, there will be absence of fundal gas. Other differential diagnoses include carcinoma of the lower end of the esophagus, stricture and your confirmation is to do an upper GI endoscopy and biopsy. You do manometry. So you should also be aware of the difference in presentation between esophageal tumors and achalasia. Now, for esophageal tumors, you know the carcinoma, they present with a progressive dysphagia, and the duration is shorter with associated features of malignancy. Now, for achalasia, you know the dysphagia is recurrent, longer duration, dysphagia to liquid followed by solid. While in carcinoma is dysphagia to solid, then liquid. However, at the terminal end of achalasia, it has dysphagia to both liquid and solid. That might be a little differentiating factor, but you should know the difference in taking the history to differentiate esophageal tumor from achalasia. Now, barium meal. Barium meal, as we mentioned, outline the stomach, and it is also indicated in patients with gastric outlet obstruction, okay, gastric tumors, and you see a filling defect within the stomach. In GOO, you might see a dilated stomach that is roomy and failure of contrast to empty into the duodenum. Okay, you might see a dilated stomach that may even reach the level of the pelvis. Roomy, absence of drainage of this contrast into the duodenum. Now you might see some shadows of your food residues. So you might see filling defect in tumors. You might see dilated stomach with absence of drainage into the contrast into the duodenum. All these are findings you might see in barium meal. Now, you should also know patients might present with GOO secondary to antral tumor, or GOO secondary to cicatrizing duodenal ulcer. Patient with chronic duodenal ulcer with cicatrization. You should know that patient with GOO secondary to antral tumor, they do not commonly present with a dilated stomach. While patients with GOO secondary to cicatrizing duodenal ulcer, they usually present with dilated stomach. Why is that so? Because the duration of symptoms for carcinoma is shorter. They have little time for prolonged contraction against an obstruction for the muscle to hypertrophy, distend, and elongate. While for cicatrizing duodenal ulcer being a benign condition, they have more time to be contracting against the obstruction. Now, the bottom line is not all about the barium meal per se, but in your exams, the questions that follow are usually around gastric CA and gastric outlet obstruction. Because there are several questions that may follow. For example, common causes of gastric outlet obstruction in your own environment, cicatrizing duodenal ulcers, gastric cancers, edema around an active peptic ulcer disease. What are the electrolyte changes in a patient with gastric outlet obstruction? Patients with gastric outlet obstruction will present with features of hypochloremic, hyponatremic, they will present with hypochloremic, hyponatremic, hypokalemic, okay, metabolic, alkalosis. With paradoxical aciduria. Now, sometimes this patient will also have hypocalcemia. Now, during the question and answer session time, we will discuss these features. You should remind me to discuss the reason behind all these presentations. Okay, so let's go back to our images. Now, you should know questions behind all these images are related to the pathological conditions they present with. Sometimes they might even ask you, what are the clinical features the patient may likely present with? What is the definitive test you want to do for the patient? Okay. Now, for barium meal and follow-through, for follow-through is to outline the small intestine. So when you do barium meal and follow-through, it outlines the stomach and the small intestine. Of course, the difference is just the timing. You allow the contrast to flow into the small intestine. And of course, the indications include patient with, you are suspecting stricture, diverticular disease, okay? And Of course, as we mentioned, all the contrast studies are all contraindicated in patients that have perforation. If you are suspecting perforation, okay, don't. You can also do contrast study in a patient with obstruction, intestinal obstruction, especially when it is partial. You see the narrowing. But if patient is in an acute phase, you don't do contrast study. Okay, so the barium meal and follow through, you outline the small intestines for pathologies like stricture, obstruction, polyps, diverticulum, and so on. And also, it is done for patients with enterocutaneous fistula. Sometimes fistulography might be difficult. You might find it difficult to cannulate the tract of that fistula to inject a contrast. So it is easier for you to do a barium study to see if the contrast will leak onto the skin, okay? And of course, if it is an end fistula, you know it will not pass to the distal segments of the bowel. So you can also employ a barium meal and follow through in some enterocutaneous fistula. Now, when you talk about barium enema, you ingest, you instill barium into the rectum. Okay, so there's instillation of barium into the rectum. When you instill to outline the large bowel. Now, it could be a single contrast or a double contrast barium enema. Single or double contrast barium enema. Now, what is the difference between single contrast and double contrast barium enema? By the way, if you do a barium enema, you are looking for features of filling defect, narrowing, shouldering effect, okay, apple core deformities in the large bowel. Single contrast, you use only barium as the medium for the evaluation. While double contrast, you use barium and air. So air is insufflated as well as barium. So both air and barium are instilled into the rectum, okay, to give a double contrast barium enema. Because if you instill only barium, it will give you a proper anatomy of the lumen of the large bowel. Now, if you do a double contrast barium enema, instilling air, it's going to give you a better outline of the mucosa of the large bowel. So if you have a bowel, okay, you have the barium in the lumen, okay, and the air between the barium and the wall of the bowel, okay. So it's a double contrast. Now, the double contrast will give you a better anatomy of this mucosa. If there is any lesion on the wall, it will show you a better outline. In a patient with change in bowel habits, tenesmus, recurrent constipation, or other forms of lower gastrointestinal symptom, you do a barium enema. Okay, they can present with a feeling defect. Okay, they can present with apple core deformity. They can have shouldering effects. These are several findings you see in barium enema. Now, you should know the definitive diagnosis is to do a colonoscopy and biopsy. And you should know, for you to do a colonoscopy and a biopsy, you must do a proper bowel preparation so that you will visualize the large bowel. If there is any lesion, you see it with your eyes. You now pick a biopsy for histology. And of course, when you are doing colonoscopy, the evaluation of the large intestine is actually done during withdrawal of the colonoscope. Now we are going to talk about CT scan, brain CT scan. Now you should know the brain CT scan is a modality for evaluating brain pathologies, usually for brain tumors, brain abscesses, intracranial collections from bleeding following trauma, okay, intracranial hemorrhage, and other lesions. You should know that when you do a brain CT scan, the report or how you describe your lesions, you use densities. You remember when we talked about X-rays, we use opacities. And of course, in ultrasound, we use echogenicity. Now, densities are used when describing lesions in CT scan. And your reference point is the brain tissue. This is the brain. This is the skull. And the whitey, this darkish, is the CSF in the ventricle. Now, since we use the brain as our landmark, lesions that have similar density, similar appearance with the brain tissue are isodense. Lesions that are darker than the brain tissue are hypodense. Lesions that are whiter than the brain tissue are hyperdense. You can see the bone is hyperdense and the CSF is hypodense. The skull is hyperdense and the CSF is hypodense. Now, when there is fluid collection that is clear, like water just like CSF, okay, that doesn't have any mineral ion in it. They appear hypodense. If you have collection of fluid that have mineral ion in it, like blood that has iron in it, they appear hyperdense. You see the bone, the skull has calcium in it, so it appears hyperdense. Okay, so if a patient presents with bleeding, okay, because the blood contains iron, at that point of presentation, the collection of blood will be hyperdense. Now, because that accumulated blood will gradually lose its iron, the body tends to reabsorb the iron content of that accumulated blood. So that hyperdensity gradually reduces. So at the acute phase, it's going to be hyperdense. At the subacute phase, where most of the iron is being absorbed, it becomes isodense. Then at the chronic phase, where most of the iron have been absorbed, it becomes hypodense. So a patient might have bleeding into the skull, bleeding into the brain tissue within the cranium. At presentation, you saw it was hyperdense. Later, it became hypodense. Okay, it's because of the progressive absorption of the iron content of the blood. Now, this CT scan will show all the layers of the skull. It will show the brain and all its covering. As you can see here, you can see the skin, the skull, okay, and the brain. And you can see there are multiple skull fractures and depressed skull fractures. Okay? So it's even showing you the X-ray of the skull. Usually in a CT scan, you will see the scanogram that shows the initial X-ray of that skull. Now, let's look at this image. You can see this is a brain CT scan, okay, that shows a lesion here. Look at this lesion on the left side. You can see the shape of this lesion. It's concave on this side. So it is convex outward, and it's also convex inward. So it is biconvex. It's biconvex. Why is this lesion biconvex? So because this bleeding is between the skull and the dura. If this is the skull, the bone, okay, and this is the dura, and you have collection of blood, okay, this blood here will take the impression of the skull on this side, and it will also exert pressure on the dura because the brain is a soft tissue. It compresses on it, so it will take a biconvex shape. So when you see a biconvex, it means that lesion is in between the skull and the dura. So you can call that lesion an extradural lesion outside the dura. You can also call it an epidural lesion. So when there is bleeding between the skull and the dura, it is called extradural hematoma or epidural hematoma, and they usually present as a biconvex appearance. From this image, we've noted that one, this lesion is extradural because it is biconvex. Two, from this image, we can say it is an acute lesion because the bleeding there has a lot of iron in it. It's a sudden bleeding. Most of the iron has not been absorbed. So you can describe this lesion as an acute extradural hematoma or acute epidural hematoma. So what is acute epidural hematoma? It is intracranial hemorrhage where there is bleeding between the skull and the dura. Okay, and usually following trauma, there is injury to the middle meningeal artery, okay, commonly, and this bleeds. And of course, this bleeding does not cross suture line because at these suture lines, you know, the dura is attached to the skull. So you either have it here, here, on one side. They do not cross suture lines because at the suture lines, you have attachment of the dura to the skull. So what are the features of epidural hematoma? One, they present with loss of consciousness, lucid interval. So lucid interval is seen in patients with epidural hematoma, which is a period of awareness between two loss of consciousness. If a patient sustained head injury at the primary impact, they lost consciousness. Okay? So after they regain their consciousness, they've already sustained injury, and blood keeps on accumulating gradually, okay, until it raises the intracranial pressure to an extent that patient will relapse into loss of consciousness. That is the second loss of consciousness. So that period of awareness where the patient wakes up, okay, is the lucid interval, and it's characteristic of epidural hematoma. So how is it treated? It is treated by craniotomy. The treatment of epidural hematoma is craniotomy. So craniotomy means you raise a flap of this bone here, okay? You remove this flap of bone, suck out the clot here. You evacuate the clot. Then you now replace this bone. That is craniotomy. You don't do borehole for epidural hematoma because when you do a borehole and insert your catheter, the catheter will just get lodged in the clot. It will not suck out the clot. So you rather do craniotomy. You raise a flap, you remove a flap of bone, evacuate the clot. Then you replace the flap. Okay? Now, what are other features you see on this image? You can see there's a midline shift, okay, to the contralateral side. You can see there's effacement of all the sulcus and gyri, and you can see there's obliteration of the ventricles. So you don't just concentrate only on bleeding. There are some other features you also look out for in the patient with brain that present with a brain CT scan. Okay. Now, if you look at this image, you see there is a collection here, and the shape of this collection is crescentic. It's like a crescent. So it is concave on one side and convex on another side. So it's a concavo-convex crescentic appearance. That is one. And two, here you can see it is hyperdense. Okay, why is this different from the other? This is crescentic. It means the collection is beneath the dura. Okay, if this is the skull, this is the dura, the bleeding is here. So it's just taking the shape of the dura. So you can call it a subdural hematoma. So a subdural hematoma present with a crescentic shape or concavo-convex appearance. And you can see for this particular image, you have an acute subdural hematoma. You can see a midline shift. You can see bleeding into the ventricles. And here there's almost effacement of this. And you can see all the, so there's edema around this. And also there's loss of the sulcus and gyri of the brain. How is it treated? Okay, you do a borehole. Okay, use a catheter, pass, make incision on the dura. Okay, because it's subdural, you can see the blood is in a liquid form, and you now drain it. Now, if you look at this, what is the shape? And mark you, if you go back to this crescent can cross the opposite side because it is between the dura and the brain. There is no any attachment to the skull. If you look at this image, you can see it's crescentic. Okay, and also it is hypodense. So this is a chronic subdural hematoma. So this is the completion of the imaging lectures we started. So it is now time for question and answer session. If you have questions, please, you can all unmute yourself and ask your questions. Thank you very much for participating. Any question? Yes, are we together? Any question?
Thank you for this presentation, sir.
Okay,
you said you should remind you about the hypochloremic, hyponatremic, and hypokalemic presentation of gastric outlet obstruction.
Okay, the electrolyte changes in
Yes, sir.
gastric outlet obstruction. Okay, this one is my own question. Any question, I'll answer it. Let's start with your own question. Okay, so everything is clear. You don't have any question. Let's go ahead and answer this question. Now, I told you in a patient with GOO, they have hypochloremic, hyponatremic, hypokalemic, metabolic alkalosis, and paradoxical aciduria. Now, they may also present with hypocalcemia. The chief complaints of patients with gastric outlet obstruction is recurrent vomiting. And this vomiting is predominantly of acid. This vomiting is predominantly of acid, HCl, hydrochloric acid of the stomach. And they lose a lot of chloride, presenting with hypochloremia. So that is the first electrolyte prevention, this electrolytemia, hypochloremia. Now, because of the loss of acid, they become alkalotic. Okay? Because of the loss of acid, they become alkalotic. And a patient with metabolic alkalosis, they have a lot of what? Bicarbonate. That is why they are alkalotic. The body tends to what? Excrete this bicarbonate out of the body in the form of sodium bicarbonate through the urine. And because of the loss of this sodium bicarbonate, a lot of sodium is lost in the urine, coupled with a lot of sodium that is lost from the vomiting. So they present with hyponatremia. Okay, we've seen how they develop hypochloremia, how they develop alkalosis, how they develop hyponatremia. When a patient has hyponatremia from any cause, there is release of aldosterone. The aim of aldosterone is to cause reabsorption of sodium, water. Okay, is to cause absorption of sodium and water from the proximal convoluted tubule. Now, with reabsorption of sodium and water into the system, there is loss of potassium as a monovalent ion in exchange of sodium ion into the urine. Sodium is reabsorbed, potassium is excreted, coupled to the potassium that is lost via vomiting. So you have hypokalemia. So there is hypokalemia. Okay. Potassium is very essential in neuromuscular function and cellular metabolism. Now, when the potassium loss in the urine gets to a critical level, that body neuromuscular metabolism cannot tolerate this critical level. Okay, there is now exchange of potassium with hydrogen ion. Since hydrogen ion is monovalent, this potassium is now reabsorbed instead of excreted from the kidneys into the urine, while hydrogen ion is being excreted. Okay. Now, when hydrogen ion is excreted into the urine, this is what? Acidic. And when a urine is acidic, you call it what? Aciduria. A patient is alkalotic. The blood is alkalotic. And paradoxically, they are excreting urine, acidic urine. Alkalotic patient excreting acidic urine. So this is paradoxical. So they have paradoxical aciduria. So let's go back. Patient has hypochloremic, hyponatremic, hypokalemic, metabolic alkalosis, paradoxical aciduria. So who can tell us why the patients may develop hypocalcemia? Any attempts? It's your own turn to speak now. Yes? Any attempt? Are we all together?
Yes, sir.
So who can tell us how patients develop hypocalcemia? I believe you all understood how they develop all these other electrolyte abnormalities. Is it clear? Okay, you should all unmute yourself. All of you should unmute yourself. Let's be together. I shouldn't be the only one talking. Who will tell us how patients develops hypocalcemia in gastric outlet obstruction? Who want to attempt? Just an attempt.
Sir.
Yes.
So since the body has lost almost all the monovalent electrolyte.
Let me be writing what you are saying so that it will make sense.
That is no need to write.
No, we want to be clear. Don't confuse us. Okay? Monovalent what?
Electrolytes, the cations. Yeah. It has lost the monovalent cations.
Yes, go on.
Especially sodium, hydrogen, and potassium.
Yes.
So it will try to through the kidney to conserve them.
It will try to what?
To reabsorb these cations, these monovalent cations.
From where?
In exchange, the kidneys.
You said it has lost all of them.
Yes, sir. In exchange for calcium. So calcium will be lost.
Which metabolism of calcium is that?
So I don't know.
Is there any metabolism of calcium that absorb exchange? Well, you tried, but it's not correct. Any other attempt?
So I think calcium is absorbed in the small intestine. So naturally, when there's gastric outlet obstruction, the calcium to be absorbed is not reaching that part of the intestine, that part of the bowel. So there'll be hypocalcemia.
Yes.
No.
No.
Right. Yes, that is a good attempt.
Wow.
Who else? Who else? Okay. Since you don't know, I'll give you a clue, then give you an assignment to go and check. Okay?
Okay, sir.
You have metabolic what?
Alkalosis.
Okay. Alkalosis. Okay. So, what is the relationship between calcium ion, hydrogen ion, and albumin? Okay. The relationship between acidosis or alkalosis with calcium and albumin. And you should know that this and this are monovalent. This is negatively charged, this is positively charged, and these two compete for a binding site here, okay? But this patient is alkylating. So you should go and check the relationship between alkalosis, acidosis, calcium, serum albumin, and a patient with gastric outlet obstruction. So we have come to the end of this session. You want to attempt, after I told you it's an assignment, you don't want to read, go and read. So we have come to the end of today's session, okay? So we are done with the imaging. So we are going to proceed with other things, okay? Thank you very much.
Thank you, sir.
Thank you, sir.
Welcome.